Well, hello, everyone. Welcome back to another episode of CRNA's Prep Academy podcast. I'm your host, Jenny Fennell, CRNA. I'm so happy to have you here again today. Today, we're going to be doing an episode over labor and delivery patients, or just being pregnant in general, kind of physiology. This was an episode that was requested by one of our community members, so thank you for the request. Again, if you have any requests, please feel free to let me know. I love to hear what you want to hear about. So today we're going to just kind of go over, again, the physiological process of being pregnant and kind of what that means as far as anesthesia implications. So being pregnant, I've been pregnant 3 times. So I can say if you're pregnant right now, you may want to come back to me a little bit later, because if you're like me, being pregnant is kind of it's a lot, and it can be scary. So I don't want to anyone who's already pregnant, unless you're in school, then you're going to have to learn it regardless. But again, some of this can be a little bit kind of like, wow, it's kind of a lot to take in. And I think being pregnant, like I said, is kind of already a scary time. So if you worry about being fearful of being pregnant and what all it goes into that, then maybe you should come back to this episode down the road. Not that, again, anything in here is super scary, but again, I just want to make sure I'm bracing you for impact that, being pregnant, while it's beautiful, it's a wonderful thing, and your body is an amazing, just has this amazing ability to bring another life into the world. There are a lot of changes that occur to your body, and some of them come with risks that are associated with that. So we're going to kind of cover some of the things that as an anesthesia provider that you should know to make sure you're providing safe care to your pregnant patient. So first, I want to kind of point out that when you are pregnant, again, I've mentioned how you have a lot of physiological changes that occur in your body. And just overall, I want to point out that getting general anesthesia while pregnant is risky. It's risky in this, which is why we don't tend to do it routinely. It's not our first choice of the type of anesthetic we would provide. We usually do spinal anesthetics or epidural anesthesia. You can have surgical numbness, or I'm trying to think of a term that you guys understand if you're relatively new, but you can create kind of a surgical field with an epidural. I think a lot of people think you have to have a spinal epidural for surgical pain to be not felt, but that's just not true. You can actually dose an epidural to get surgical anesthesia. Okay. And so whether or not you have a spinal or an epidural, the other option, if you need a C-section, if you do not have either one of those and there's no time to do a spinal, then the other option is to have a completely just a general anesthetic, which is what we do for everyone else who comes in for any kind of general surgery. They go completely under with anesthetic gases. We put them to sleep through their IV. So that is obviously the backup method that we use for pregnant patients. And there are reasons for that. And we'll kind of go into that today. So again, it says here about 1.7 deaths per 1 million births is the overall maternal morbidity. Okay. However, if you look at deaths associated with general anesthesia versus regional anesthesia, and regional anesthesia is epidural or spinal anesthesia for surgical procedures, you're looking at 32 maternal deaths per 1 million births with general anesthesia and 1.9 maternal deaths per 1 million with regional anesthesia. That's a pretty big, significant number, which is why I wanted to kind of caution you guys before I said that little statistic. If you are pregnant, hopefully I'm not scaring you. But I want to point it out because it is very significant, which is why general anesthesia is not our first choice for someone undergoing, say, a C-section, for example. So again, most deaths occur during or after a C-section. And again, the risk is almost twice that with any surgical procedure. So C-sections can be risky, especially under general anesthesia. I want to point out that, C-sections are essentially done for non-reassuring fetal heart rate or pattern. It doesn't necessarily require a general anesthetic. Okay. Like I said, a lot of patients have a working epidural and then all of a sudden baby is not doing well. Well, then they can rush back to the operating room and very quickly be anesthetized to where they're very numb, but yet still awake. They're still talking to you. And I've been part of those types of cases before. And one of those are very scary experiences, not only for the patient, but just everyone in the room's on edge. It's usually a very urgent thing. So you're trying to save baby and you got to keep mom safe. So what's challenging about OB anesthesia is you're taking care of 2 lives now. You have baby and you have mom. As an anesthesia provider, your focus has to be on mom. You have to let the OB team take care of the baby. I know that sounds kind of like, well, don't get me wrong. It's not like you don't think about the baby at all, but If mom's not going to make it, baby's not going to make it. So you really have to focus your attention on taking care of mom and making sure mom's safe, because that will ensure baby's safety. That means making sure her blood pressure is safe. That means making sure that she's oxygenated. Because again, think about all those things play into how baby's perfused and how baby's oxygenated. So your main focus is taking care of mom. Okay. You let the OB team handle the baby and get the baby out safely. Okay. But you do want to think about things like, do you want to slam her with fentanyl, or do you want to maybe use a drug like ketamine? Because think about it, if baby's still in the body and you push a bunch of fentanyl, baby's now going to be affected by that fentanyl and have really poor APGAR scores and barely be breathing. So ketamine is usually a better drug of choice for an analgesic. And so you want to make sure you're keeping that in mind. Again, when you're pushing drugs for mom to go to sleep with anesthesia, typically it's propofol and sux tube, and they cut, so as soon as the propofol is in, they typically are, if it's really truly emergent, you guys, they're going to be asking you when they lose their lid reflex, meaning when they're completely out, and essentially you're going to be pushing propofol, pushing sux, getting the tube in. They're going to be cutting as soon as they know the patient is anesthetized where they're not going to have recall. They typically start their incision. And so it's very, very quick. I have been in cases where they have a working epidural, for example, and, literally they're running the patient in the bed to the OR, running down the hallway with the patient. And by the time you run up to OB, you essentially run into the OR first thing, you grab your lidocaine and your bicarb and you mix it up really quick. You meet them in the hallway, you assess them as you start pushing that epidural. First you want to make sure you have a working epidural. That's one of the first things you always want to assess. Because then your backup plan obviously is to go all the way to sleep. You want to make sure your epidural is working, and you start pushing. Okay. You start pushing to get them to where they have surgical analgesia. You test them, you make sure that they're numb, you reassure them. A lot of your job at that point is to reassure them that you're going to watch them as closely and carefully as possible to make sure that they're safe and baby's safe. Imagine how anxiety provoking it is to run back to the OR. I mean, here you are to have a baby and you're all excited, and next thing you know, it's life and death for both you and baby potentially. And it's very, very scary. And a lot of these patients don't have any medical experience or any knowledge of what's going to happen, and they're terrified. Moms are terrified of feeling the baby being ripped out of their body. You have to reassure them that they're going to be completely numb before any cut happens. You have to make sure you're talking to them and reassuring them that they're going to be taken care of. So it's a very, very stressful and yet important role for you as an anesthesia provider to do for these patients. And I'll tell you what, as much as I loved OB, because I love babies, I love babies. I love them. It's very hard. It's very challenging because a lot of it, like I said, is more dealing with the sociological stress of what they're going through and really talking them down, because they're awake feeling their body being cut into. And while, you have a spinal, you have an epidural that works, and you don't feel this sharp stabbing pain, you feel the pressure. You feel the pressure the entire time. And it has to be super disheartening to just feel like this immense amount of pressure in your abdomen that's just like going to make you want to explode. And I've had moms tell me, like, when their uterus is up on their chest and they're kind of sewing up the uterus, they get kind of like the shoulder pain that makes them kind of feel like their chest is tight. Sometimes when the spinal epidural raises a little bit too high, they lose the sensation of breathing. Can you imagine that? Like, I can't feel myself breathe. You are breathing, but you can't feel it. Can you imagine what that would feel like? You probably can if you've never experienced it. But I can only imagine it would be scary to think, I don't think I'm breathing, because you're not sensing it. Your body's too numb to it, but you are breathing. And so it's a very scary, scary thing to go through when you're completely awake. And so ideally, don't be afraid to give Versed. If you need to give Versed because mom is just, losing it, give some Versed. Baby will be okay from a little bit of Versed. So don't ever be fearful of treating mom for her anxiety if it's needed. I would a lot of times ask what Pandora station they like and put on my Pandora for mom to listen to if they were open to that. Just giving them something else to focus on versus feeling themselves being, the pressure of being cut into, and just talk to them, ask them what their baby's name's going to be, or do they have any siblings, and just, that's part of your role when you're an OB, is to deliver that kind of customer service part where you're just being a human to human and sharing, human to human, kind of relating to them and letting them feel at ease that you do care about them as a person. So I just want to preference all this with all of that backstory for you guys and my experience with OB. But it is amazing to see babies be brought into this world because, again, your bodies are incredible. And so one thing that getting into the physiological effects of being pregnant is your increased risk for aspiration. Okay. You're always considered to be a full stomach when you're pregnant. And if you've experienced being pregnant, you know exactly why that is, because you have probably experienced laying down to go flat to go to bed and having raging heartburn where you just have this, it hurts. Like you feel like you have this pain in your throat. Sometimes you may even puke a little bit when you lay flat. Yeah, it's not fun. And it's because you have all this abdominal pressure and your lower esophageal sphincter tone is lessened. And so that regurgitation can come up into your esophagus. So you were always considered full stomach when you're pregnant. So other things to kind of just run through that we're going to kind of cover in a little more detail is, being pregnant, you can feel breathless, you can have airway swelling, you can have congestion. Most people who are pregnant, especially towards the end of pregnancy, can't breathe through their nose anymore because all of the swelling. You typically, again, have nausea and vomiting and GERD. Always ask about this. I mean, it's a very common question, regardless of what type of procedure you're doing, regardless if you're pregnant or not. But even if you're prurient doesn't experience heartburn, still treat them like a full stomach, okay? Because they are still at risk. So don't think, oh, well, they don't have any symptoms of heartburn, they denied it, they're going to be fine. And you can't ever assume that. And I'll tell you right now, holy cow, can pregnant people puke? Like it's pretty much a given that you're going to lay them flat and their pressure's going to drop just a little bit and they're going to go bleh. Their vagal tone is increased when they're pregnant too. And they're very sensitive to pressure changes, naturally so, because it's their body's way of saying, hey, we need this perfusion pressure to keep your baby alive. We got to react to this. And so they're just very sensitive to fluctuations in blood pressure. A lot of times too, they can have back pain. And so you have to take that into consideration too, what's comfortable for your patient. And that can make it really hard, you guys, to actually do an epidural, do a spinal, because they may be experiencing a lot of back pain. And here you are asking them to essentially touch their toes and hug their belly. It's like, it's a little easier said than done, so trying to get them in a comfortable position to allow them to get a spinal or epidural. It's much easier to hang their legs over the side of the bed than try to sit Indian style with a giant, 3 basketball size thing in your abdomen. So making them comfortable while you're doing this, I always put the legs down a little bit to help them, or dangle their legs off the side of the bed. So another thing that changes a lot in pregnancy, and one of the big things, is the fact that oxygen consumption increases during pregnancy. Okay. So your metabolic rate increases out of proportion to mom's body and weight and surface area. The fetus and the placenta and the uterus consume O2 and release bicarb CO2. I'm so sorry. See, mama brain, as it lives with you forever, I promise. And again, they or have a higher metabolic rate overall. Okay. So the highest rates of fetal metabolism is during the periods of most rapid growth, which I actually find very interesting. You will notice, like, again, when you're pregnant, there'll be like a week where you're going to gain 2 pounds in 1 week. And you're like, whoa, so, and it's because your baby is growing rapidly. And so are you. So during those times, you actually have a higher metabolic rate and you're actually producing more CO2 during that time. Another thing too, is the weight gain during pregnancy. They say the average is right around 30 pounds or 12 kilos ish, 12 to 13 kilos. However, that's, if you start with a higher BMI, they actually tell you you need to gain less weight. Okay. But then there are some women, for whatever reason, they gain way more than that. They gain 60, 70 pounds. Okay. Even if they were starting at a normal BMI, they can gain a lot of weight. So that can make doing your epidural and spinal very difficult, because a lot of doing these procedures is based on landmarks. It's a blind insertion. Where your spine is, and you can try to feel the vertebral spaces to find where to go in between those spaces. But again, if you're really obese, it's going to be really hard to push hard enough on the skin to really get a good feel for, are you going to be midline, and are you in, low in the space? When you're doing an epidural or spinal, you want to go low in the space, not high in the space, because you're going to end up hitting bone if you're high in the space. And again, this is clinical, way over your head. It's totally cool. I'm just rattling off what I know. But again, the weight gain can really make anesthesia more complicated. So essentially, general anesthesia is really only done for failed regional or true emergencies that do not allow time for a spinal, for example. Like I've done spinals with urgent sections, you know, not emergent, but urgent, meaning we got to get this baby out, they're monitoring the baby the whole time. But what can happen, and this has happened, which is very scary, is where an urgent section can turn to a stat section, meaning baby's not doing great, but they're okay, meaning they recovered, but they're down, their heart rates are down for longer than normal, and they're taking a long time to come back up, meaning baby's distressed. They could have a cord around their neck, you know, whatever, we don't know. There could just, something's not going right. And so, and that's usually a lot of times it's what it is though. But that being said, what can happen is you could do that spinal, drop their blood pressure, and they could lose tones altogether, because that little bit of change in blood pressure can really make a huge difference. You always want to start by asking how much fluid bolus they've had. You always want to make sure you're adequately fluid bolusing them. Triple, quadruple check your IV, especially if you're running back to that stat section. Do not take someone's word for it, okay? You do not want to give someone a spinal or slam them with some local anesthetic and drop their blood pressure and not have a working IV and no way to get their blood pressure up, because now baby's in even worse shape because you've lost even more perfusion to the fetus. And so flush the IV, draw back on the IV, preemptively give some neosynephrine, or, you know, like essentially as soon as I give that spinal, I'm giving neosynephrine, Zofran, all of that, like pretty much one of the first things I do, other than oxygen, you know, finish putting them on the monitors, whatever. It's all somewhat happening simultaneously. But again, I'm speaking from experience that sometimes when you give that spinal, you're dropping their pressure enough to where now an urgent section becomes a stat section, okay? And again, if you don't have a working IV, yeah, you want to make sure you have a working IV. So always triple check. Do not just take someone's word for, oh yeah, their IV is working, because I've had them come back where they say they're working and they're on a pump, but they're infiltrated and no one caught it because the pump was still giving fluid through an infiltrated IV. Okay. You should always have a glide scope that's available. And most OB suites will have one in the room. A lot of times they'll even have like maybe a McGrath, which is like the small little video scope that it works on batteries. So it's kind of always like on standby. It's small, it can fit in a drawer. If you don't have one, have a glide somewhere nearby that you can easily grab it. Again, we always had one. Our OB suite was only like 3 rooms. It was really small, but we would run 2 rooms simultaneously for like sections and stuff. We had the one glide was between these 3 rooms. And so it was right out in the hallway. It was really quick to grab it, but we always knew it was right nearby. And make sure it's charged. That's not, don't always, when you're going in the morning to do your machine checks and set up your room for the day, make sure that glide scope is plugged in and charged. The last thing you ever want to do is have that one glide scope available, go to use it and no one plugged it in and it won't turn on. So that is part of your responsibility, to double check your equipment in the morning, including your glide scope, to make sure it's charged. Okay. Also, you want to just make sure you're collaborating with the OB. This is a huge part of doing OB anesthesia, you guys. You have to talk to the OB team. You have to understand, and you meet for rounds. Like, so when you go up for the OB today, you meet in rounds, you understand, you know, what their history is, what their risk factors are, if any. And then you always preemptively assess them ahead of time for an epidural or spinal. This allows you to where if you have, like, say, a crash, whatever, you've already done your assessment on them. And so it kind of allows you to quickly expedite things. And so it's really important to, if you think anyone's going to need a spinal or epidural, to get ahead of the game. And as soon as the nurse tucks them in and gets them settled, go ahead and just doesn't mean you have to like document everything right at the moment, but just do your assessment, talk to them, answer questions for them. That way, if it turns into kind of more of an immediate thing, you've already essentially touched base with the patient, understand their history and what they need from you. And they have their questions answered too. It's always a good practice to start your day up in OB that way. So airway issues. Okay. So when you're pregnant, you have a lot of swelling. As I said, sometimes you can't even breathe through your nose towards the end of pregnancy. You are swollen. You can't fit your shoes on. I mean, it's just, oh, it's misery. But including your airway is not immune to being swollen. It can be swollen as well. One thing that could be a really good indicator to whether your airway may be somewhat compromised due to swelling is, are they raspy? Is their voice raspy? That's a really good indicator. But again, just assume that all pregnant girls have some kind of edema going on. You usually typically always downsize your endotracheal tube to a 6 or 6.5 tube. So again, it can definitely be hard, you know, again, to intubate, which is again why glide's nice to have on standby. And so again, with your upper airway, you have capillary engorgement of the mucosa. You know, essentially edema is exacerbated by eclampsia. So if you have someone who has hypertension, you're always going to have patients who are in special care. You have to, that's what part of your rounds to find out, why are they in special care? A lot of times it's because they have blood pressure issues or something in their history that puts them at higher risk overall. But think about it. If you normal pregnant people with normal blood pressure have swelling. So if you already have high blood pressure, you're going to have even more swelling. So again, some anesthesia implications for the pregnant patient. It's a difficult airway. You want a smaller cut or smaller endotracheal tube. You want to make sure you're gentle with instrumentation. Not only are they swollen, but they're more friable, meaning like they're more apt to, if you were to be too aggressive with your Miller blade or whatever blade, any metal blade, you can cause bleeding in the airway, which, yeah, that's always a bad thing. You don't want to make a bad situation worse. You have to be really gentle when you're instrumentating their airway. Okay. Nasal trumpets. I mean, I would really exercise extreme caution, maybe even put some Afrin up their nose prior to even doing it. But try to avoid it if possible. I mean, there's other methods you can do besides sticking on a nasal trumpet. That being said, they'd have to be pretty sedated to take a nasal trumpet. You know what I mean? Like, I mean, think about it. Nasal trumpets are usually for someone who's like completely, I mean, don't get me wrong, they'd be pretty sedated to be able to take that. No person who's somewhat awake is going to appreciate a nasal trumpet. So that's number one. Why do you need a nasal trumpet? How much sedation did you give them? You know, is that if you have a good spinal epidural, that's not necessary usually. Okay. So just something to think about. Let's see. So airway changes are essentially, it's imperative because of the swelling of the airway and because it can progress, meaning, okay, you come in, you just get tucked into the labor and delivery unit. They start that fluid bolus, right? Because they always do. And you've been in labor now and for hours and you're getting more swollen, you're tired, maybe even you've been pushing for hours, which can also aid in how swollen you are because of the increased pressure that you're dealing with. You're bearing down and having this increased pressure. It's really imperative to reassess that airway, you know, and also have it in your mind, even if they start off as a Mallampati 1 and you're like, oh, there'll be no problem, that airway is going to be swollen. Okay. So you always want to exercise that caution, especially if they're further along in the process and they've been pushing for a while, they've been getting fluid, they're going to be way more swollen than they were when you first assessed them. Okay. Some respiratory changes in pregnancy. So your minute alveolar ventilation increases by 45% at term. And what that means, that's a fancy alveolar ventilation. So alveoli are your air sacs in your lungs. So again, you increase your overall ventilation of your air sacs in your lungs, okay, by 45% at term. So it's stimulated by the increase in progesterone in the first trimester and throughout your pregnancy. You also have an increased tidal volume, 40% on average increase, and an increase in your respiratory rate by 15%. Okay, so this overall leads to an increased alveolar ventilation and increased O2 consumption, which is about 60%. So you have all these changes in your respiratory system because you're actually consuming more oxygen. You need more oxygen. You also will be, because of this, be slightly respiratory alkalosis. So you'll have a slight respiratory alkalosis. However, your body is able to compensate through renal excretion of bicarbonate ions. So you don't become alkalotic, but you essentially have some compensation going on to keep your pH normal. Okay. So your FRC decreases at 20% at term. And I actually kind of want to go over briefly because some of you guys might be like way over your head. You might be like, Jenny, what the heck is FRC? Like, I don't understand any of these terms and I'm just getting confused and I don't want that. So let's kind of break it down a little bit. So your tidal volume on average, like if it was me and you, I'm not pregnant, I hope, anyways, is 7 mLs per kilo. Okay, that's just a ballpark number. Okay. And so what comprises your functional residual capacity? So your functional residual capacity is essentially a combination of your expiratory reserve volume and your residual volume. And so what are those two things? Let's break that down. So if you were just breathing normally, okay, like just right now, breathing normally, and you were to force an exhale, meaning like breathe everything out of your body, you have just now collapsed or used your expiratory reserve volume. However, I will always have a residual volume, always. You can never, that's like always there. And your residual volume is approximately 15 mLs per kilo, where your expiratory reserve volume, the or whatever, if you forcefully exhale, is 15 mLs per kilo. Now, the combination of those two, meaning your residual volume and your expiratory reserve volume, which are each 15 mLs per kilo, comprise your functional residual capacity, which is approximately 30 mLs per kilo. Okay. Now, obviously, some textbooks might say a little bit different, but I'm giving you guys, again, ballpark numbers. Okay. Now, that being said, if you're not forcefully exhaling, you're simply breathing 7 mLs per kilo per minute all the time. Okay. You also have what you call an inspiratory reserve volume, which is where you take a big inhale and breathe really, really deep. Okay. And so you have that capacity as well. So when you're looking at something like your vital capacity comprises of your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume. So now if you were to take a giant breath in and forcefully exhale at the same time, you have just covered your vital capacity. Okay. I just want to make sure I'm explaining these terms to you guys so you kind of have an understanding when I'm talking about the differences in pregnancy when it comes to lung volumes. So other things to keep in mind too is that your lung compliance does not change. Your dead space does not change. Your total lung capacity, vital capacity that we just went over, and inspiratory capacity, there's minimal to no change. All right. However, your minute ventilation increases by 50%. Your tidal volume increases by 40%. And so what does that mean? So if you're breathing 7 mLs per kilo, you're going to be increasing your tidal volume to about 9 to 10 mLs per kilo. Okay. And then your breathing frequency increases by 15%. So if you're breathing, right around 12 breaths per minute, you're going to be breathing right around like 14 breaths per minute, give or take 13 something or another, but you're going to be breathing a little bit faster. So not only are you taking bigger tidal volumes, you're breathing faster. Okay. So as I just went over some of the lung volumes with you guys, the expiratory reserve volume decreases by 20%. Your residual volume decreases by 20%. And your functional residual capacity decreases by 20%. And the reason for this is because your uterus is pushing up on your diaphragm. Okay. Again, if you've been pregnant, you're going to understand you can't even bend over to tie your shoes because you can't hold your breath. You don't have any, and you get winded going upstairs. You don't have as much functional residual capacity to pull from. And so you're really reliant on, again, increasing your respiratory rate and your tidal volumes to get adequate oxygen. And also your demands are higher, meaning you need more oxygen. So in general, you get winded much easier. And it's funny. I remember when I first launched this podcast back in March, I was pregnant. We had our third child in April, but I had been pre-recording episodes, I think in February for the launch in March. And holy cow, you guys, it was so hard to come on a podcast being really pregnant. I was just getting winded. I remember being like, gosh, people are going to hear my breath. What I told my podcast manager, I'm like, can you cut my breath back a little bit? Cause I just sound like I'm winded all the time. And because I was, because talking was strenuous for me. So again, I just wanted to cover that again, that's just a typical finding with people who are pregnant. Let's kind of get into the cardiovascular changes in pregnancy. So you will have an increase in intravascular volume. You will also have an increase in heart rate and an increase in cardiac output, as well as an increase in heart size. And that's because you're going to increase your blood volume quite significantly, actually. So overall, increased peripheral circulation. So because of the increase in maternal intravascular volume begins during the first trimester. So it happens right away. But overall, you're going to have an increase up to 45% in your plasma volume, which is a lot. That's a lot. But you only have an increase in your red blood cell volume by 20 or 30%. So what does this do? This naturally causes a hemo or a dilution, or causing kind of like a hemodilution or anemia of pregnancy. It's common, essentially because of increase in plasma volume without proportional increase in red blood cells. It creates this dilutional anemia. Now, they say the average expansion is right around 1,500 mLs at term with blood volume, okay? They say on average vaginal deliveries, you lose around 500 to 600 mLs, and the C-section 800 to 1,000 mLs. I'm not sure, where they get these averages from in the textbook, but I can tell you from doing a lot of C-sections that if you were to lose 1,000 mLs of blood, that it's usually because something didn't go 100% correctly, or, it's not that common to have that kind of blood loss. Usually C-sections are anywhere from 500 to 600 mLs typically, if they're pretty straightforward and go well. Vaginal deliveries are usually a lot less, usually like a couple hundred, but again, I don't know, they're getting these averages from worldwide. I'm not really sure, but just want to throw out textbook numbers for you guys, for those of you guys reading textbooks. So overall, your blood volume increases by 45%, your plasma volume increases by 55%, your red blood cell volume increases by 30%, your hemoglobin concentration is typically right around 11, and hematocrit around 35, okay? So your oxygen transport is increased during pregnancy. Your low crit decreases O2 carrying capacity, however. It's compensated by an increase in ventilation. And you will have naturally an increase end-tidal CO2 production. You will also have vasodilatation of your uterus and kidneys. So increased blood flow to target organs, all right? This is also how the hemodilution can help this, because you're gonna have less viscosity, okay? That's another physics term that I encourage you to look up. If your blood's less viscous, it's going to travel faster. So also another thing to make note of is that your P50 shifts to the right. Okay, so if you don't have a good grasp on the oxygen dissociation curve, I highly encourage you to study that, because it's a very important part of what you do, and kind of understanding a lot of physiology when it comes to learning anesthesia. But typically the P50 is right around 26 or so. And again, this is based on millimeters of mercury or like the tension of oxygen. And essentially what happens is it shifts to the right. So I'm encouraging you to think like, what does that mean, a shift to the right? Well, if you know the basic oxy dissociation curve, you're going to know a shift to the right is acidosis, but the opposite is true with the P50, because in acidosis, your P50 will shift to the left, okay, meaning you're going to readily release oxygen to the tissues. And alkalosis, your P50 is going to shift to the right, because it means you're going to hold on to the oxygen a little bit more. So make sure you don't get confused. That was probably confusing, honestly, if you don't quite have the oxygen dissociation curve quite memorized, but I just wanted to throw it out there as an extra little tidbit for your studying. You will also, for like your cardiac output, so your uterine blood flow increases from like 50 mLs a minute. So like right now I'm sitting here, I'm not pregnant, my uterine blood flow is right around 50 mLs per minute. That's my baseline. When I'm at term, my uterine blood flow is 700 to 900 mLs a minute. This is why, you guys, that you can get massive hemorrhaging postpartum. This is why you can quickly bleed out after you have the baby. This is back to why, if you're pregnant, I hope you're not scared. But it is a scary thing, to think about. You're like, oh, holy cow, so it could be a very scary time, because again, you can lose a liter of blood in a minute, okay? So increase in cardiac output is primarily due to the increase in stroke volume, which is from your increase in preload, and your heart rate, all right? So those are the two main factors that go into your increased cardiac output during pregnancy: preload and heart rate. Now, another question I have for you guys is, when is your cardiac output greatest? Your cardiac output is actually greatest immediately after delivery, okay? It might not be what you think. As much as 80% above pre-labor value. This is huge. And this is due to essentially like an auto transfusion that increases venous return. Because think about it, you no longer have a baby to feed and a uterus to feed. So you've essentially lost a giant organ out of your body that was taking up a good chunk of your cardiac output and demand. And so now all of a sudden you don't have that. So you're going to have a giant surge of volume in your own body, an auto transfusion, like I said. This does return to normal about 14 days postpartum. However, the reason why I'm sharing this with you guys is because postpartum, you're at really, really high risk for congestive heart failure. There have been, routinely there's reports of women going into congestive heart failure postpartum, typically right around 48 hours. What's scary about that is typically a lot of women are sent home right around that time. And so unless this is kind of caught early in the hospital, you can go home with these symptoms and not understand what's going on, okay? So another thing to kind of be aware of that changes in your cardiovascular system is your systemic vascular resistance decreases by 20%, and your peripheral vascular resistance decreases by 34%. So this offsets the increase in cardiac output and increase in intravascular fluid volume, which is also why if you do not, if you're a patient who experiences hypertension, you're going to have more hypertension during pregnancy because, again, you're going to have increased volume to deal with. So hypertension during pregnancy can be very, very dangerous to baby and to mom. But I also want to point out naturally with some of the hormones like progesterone and things like that, you should see this decrease in systemic vascular resistance. Okay. But not everyone experiences this, which is why it can be kind of dangerous and why we watch for preeclampsia and things like that. Believe it or not, even though you have all this increase in volume, your CVP is little to no change. Okay, that's impressive, right? That means that that's how much your body expands their vascular volume and distends, the systemic vascular resistance distends, so you can kind of accommodate all this extra fluid without having, JVD. I mean, you can, if you lay flat, you usually can see somewhat of a JVD in pregnant women, but again, it's your body's way of compensating for all this extra fluid volume by vasodilating out, which is why your shoes don't fit. All right, so let's kind of go into pregnant people being supine and why you need to exercise caution with this. So when you're supine, you're going to have what they call aortocaval compression or supine hypotension syndrome. All right. This is caused by the gravid uterus compressing the maternal aorta and IVC. Essentially, all you have to know about this is usually by 20 weeks gestation, you want to avoid being completely supine. Just a little 15% bump under the right hip is enough to relieve the compression. So we call that the LUD, lateral uterine displacement. But again, we typically use the left uterine displacement position. But when you're giving birth, you're going to see mothers turn from right to left, but typically, again, if you're really looking to give the most oxygen to baby, you want that left uterine displacement. Okay, so after you do the epidural, you typically put a bump under their right hip. Okay. But really getting off their back in any direction is going to be better for the baby. All right. It's because essentially when you have this syndrome, you essentially decrease venous return to the heart. As far as blood pressure support, this is really another key thing. You're going to be dumping ephedrine and neo in these patients who are coming in for spinals. That's also why a good fluid bolus is really, really important before you give a spinal, but always make sure you have ephedrine and neo ready to go. You will use it. I personally like a combination of both. I think giving them a little bit of, speeding them up a little bit, along with a little bit of positive inotrope is good with the extra squeeze. Because you remember phenylephrine really is good for the squeeze, but not as good for the inotropy. So ephedrine has a little bit of both. And so a combination of both seems to work well. But don't be afraid, again, to make sure you have these drugs ready to go before you actually start your case. And like when I would walk around and do OB, I would have neo in my pocket, like at all times, especially like if you run into a room and you have to redose an epidural, or just after you do an epidural, you give that first initial bolus dose. You can experience hypotension and the baby might not like that. So having some neo in your pocket just in case is always kind of like, I would just ward off evil spirits a little bit. I wouldn't say it happened a lot. We used to bolus our epidurals with 0.25%, and that would cause a lot more hypotension. We started doing 1/8%, which essentially, without going into a lot of detail, is just a more diluted version of your bupivacaine or whatever you're using to get that really dense initial block for your patient. Also, if you dilute your bolus dose down a little bit, what's also nice about a diluted bolus dose is they don't go so numb to where when that actually wears off and your epidural infusion kicks in, they think that they're experiencing pain. And I can say I've had 3 epidurals and they were all different, like all different. With the last one being relatively like, holy moly, I could feel a good amount, but I had a working epidural, but I mean, it wasn't painless. I think a lot of people think they're going to experience no pain with an epidural. It's just not true. It's not true. Another thing that I experienced too is they did my epidural and I got really comfortable. And then like about an hour and a half later, I'm like, damn, this is really freaking hurting, man. And like my pit was, I don't remember, but they kept increasing my pit. And long story short, they never started my infusion. I look back at my pump and the door is open. I'm like, you need to call anesthesia because that is not running if the door is not locked and it's open like that. They never even started my infusion and I'm feeling everything. Like this freaking hurts. So yeah, I know what it's like to go numb and have it wear off. And I was like, gosh, my feet are completely fine. I don't have any tingling. I can pinch myself on my thighs. So, and it took a while to get numb again because they didn't really slap me with a big dose. They just gave me some lidocaine. I remember complaining. I'm like, can you give me more? Like, I don't think my feet are numb, but I want my freaking belly to be numb, please. I wasn't being patient. And they're like, you got to be patient. I'm like, ooh. So anyhow, but just so you know, epidurals are not painless, but heck, they're a lot better than what you would experience without it. I can 100% guarantee you that. So yeah, you just got to be careful when you're giving bolus doses of local anesthetic that you're aware that it's going to potentially decrease someone's blood pressure. Also, when you're pregnant too, you guys, your overall need, your local anesthetic dose is decreased as far as your requirements. The pregnant women tend to exhibit more rapid onset and longer duration of spinal analgesia than the non-pregnant women. So when you have pregnancy associated with elevation in cerebral spinal fluid pH, which also may contribute to these effects. Without getting into pharmacology on you guys, pH plays into how your local anesthetics work, meaning the duration of action and all that stuff. So without going into all that, that's why I wanted to make sure I back that up with understanding that the reason why I mentioned the change in pH, it's because it can actually affect the effectiveness of your local anesthetics. Okay. So again, when you're pregnant, you're potentially going to be needing less dose as far as spinal doses go than the non-pregnant patient. And essentially the reason for that is, one, you have kind of an altered condition of the spinal column caused by vascular congestion and engorgement. Again, you're going to hit so many epidural veins. You got to do your epidurals and get blood and you're like, oh, and they're just engorged. They have giant epidural veins that are in there. You also have a decreased volume of epidural space, and you also have a decrease in cerebral spinal fluid volume because of the increased pressure, okay, that you experience from the having the baby in there pushing on your spine, your spinal column. You also have, again, increased neural sensitivity to local anesthetics. You can potentially have increased spread depending on what position you do the spinal in. We tend to do all of our spinal sitting up. We did have to lay them back relatively quickly, but if you were to do, like, say, I don't know if you had to do one laying lateral, for example, they could get a spread much higher that goes up quicker because of the increased pressure. So just something to think about. There's some other issues with pregnancy. We're wrapping this up here. I'm going to kind of finish this up with some key points, some key takeaways, like your cardiac output. It increases during pregnancy as a result of increase in stroke volume and heart rate. A pregnant woman with cardiovascular disease may not be able to meet this greater demand. Even without cardiovascular disease, there are plenty normal, healthy women who go into postpartum congestive heart failure. Hopefully they recover, but sometimes they don't. So again, it's something to not take lightly and to be aware of. Beginning at mid-pregnancy, assumption of the supine position may result in compression of the inferior vena cava. So I don't know. I mean, you don't typically do elective cases on a pregnant girl, but if you were, make sure you're taking that into consideration. If you're providing some kind of anesthetic for some other reason, making sure that you're doing that left uterine displacement for them. So you're helping baby, especially because with general anesthesia, you guys, you vasodilate them more and you drop their blood pressure more. They're also more likely to hemorrhage and bleed out with general anesthesia because of the vasodilatation. So you have to make sure you take the extra precaution to make sure you're keeping mom's pressure up, you're keeping her hydrated, and you're doing that left uterine displacement. Okay. Keep in mind too that your oxygen demand and delivery are greater during pregnancy. Your minute ventilation increases, whereas functional residual capacity decreases, like we said, because of the displacement from the giant baby in your belly. So it's not uncommon for pregnant women to experience dyspnea or shortness of breath. Pregnancy is a state of partially compensated respiratory alkalosis. Gastric volume and emptying, pH are altered during pregnancy. I didn't actually get into that a little bit, but essentially I'm going to ask you guys, what's a aspiration, meaning like, what would it take to have a bad aspiration that would cause like ARDS to develop? And the answer is 25 mLs of gastric volume that has a pH less than 2.5. Okay. So what you'll see is prior to a C-section, you'll ask them, did you get your bicitrate? I've heard it tastes like sea salt, by the way, or seawater. I've heard it's not good. It tastes just super salty, but essentially what bicitrate does is it decreases your stomach pH. It doesn't decrease your volume, but it decreases your pH. So holy moly, pregnant people can puke, and they can puke way more than 25 mLs. And so again, when you're giving them bicitrate, you're essentially decreasing the gastric pH. So if they were to aspirate, it's not going to be as detrimental to the patient's lungs. You can also give something like histamine, Zantac or something like that, but keep in mind that, or Pepsid, but keep in mind the peak effect for that is 30 minutes. Typically with that, trying to think what else. Oh, Reglan, you can give Reglan. Reglan will increase your, the emptying, meaning it'll decrease your volume in the stomach. Okay. It won't decrease your pH, but decrease the volume. So if you're really worried, you give bicitrate and Reglan to the patient. Just keep in mind, if you're using something like Pepsid, which is a histamine blocker, it's going to take up to 30 minutes to really get its peak effect. So just time it correctly. We would give Pepsid and pre-op. And so maybe you've let it sit for 20, 30 minutes prior to going back to the OR. Another thing too is that you have mechanical changes in the vertebral column that influence neuroaxial analgesia. Pregnant women have a greater sympathetic tone than non-pregnant women. And essentially, I have seen pregnant women actually vagal quite easily compared to probably most. So something to keep in mind. And they're very, very sensitive to fluid shifts and changes as well. Also, the minimal alveolar concentration, or your MAC values for the volatile anesthetics, so like your sevoflurane, isoflurane, are decreased during pregnancy. However, it's unclear if the hypnotic dose requirement is altered. So what that means is MAC awake, meaning recall, that may not be altered, but overall they're going to need less anesthetic to get that deep sedation. So you just wouldn't run them as deep. Pregnant women also have a rapid decrease in PaO2 during periods of apnea, and this is related to the decrease in functional residual capacity that we've already spoken about. Pregnant women are at increased risk for failed tracheal intubation because of the edema in their airways. So it's always important to kind of have like a plan, of how to manage a pregnant person's airway, such as making sure your glide is readily available to use and having a smaller endotracheal tube. So I hope you guys enjoyed this episode on the physiology process behind being pregnant and undergoing anesthesia. And always, I thank you guys for listening and tuning in. Be sure to like and follow wherever you're watching me on YouTube or on podcast. I appreciate you guys so much. You guys all have a wonderful day, and I'll see you next week. All right. Bye-bye.